Well, good morning. This is Dr. Bryson, and this is a video on mental disorders and criminal profiling. This is for Unit 2 of the criminal profiling class. So let's get to it. First, it's important to understand a logical fallacy that we call the fundamental attribution error, also known as the correspondence bias or the over-attribution effect. Now, this is the tendency for people to overemphasize dispositional or personality-based explanations for behaviors that are observed in others, while they underemphasize situational explanations. This particular form of bias or of logical fallacy is very important to keep in mind as we study the practice, I won't call it an art or a science, the practice of criminal profiling. In other words, people have a cognitive bias to assume that a person's actions depend on what kind of person that person really is, rather than on the social and environmental forces that are influencing that person at the time. Now, when this comes to criminal profiling, that means the situational forces in the space in which the crime occurred or the crimes have occurred. So try to keep that in mind. So it's called fundamental attribution error. You need to be aware of it. You need to become intimately familiar with this concept and to be able to recognize when it is being used. Okay, now the FBI profiler's assumption that the personality of the individual can be determined by the crime scene is an example of fundamental attribution error. The crime could be contextual, not characterological. In other words, someone might have, and we're going to talk about this later on, the organized versus the disorganized crime scene. There might be a disorganized crime scene because of what was happening in the context of that particular crime, not because the perpetrator might have mental issues. Okay, so that is one of the areas that the profilers miss. All right, so let's talk about mental health diagnosis versus psychological interpretation, because this video is about mental health diagnosis. So this is going to be video 1, even though this is unit objective 3 that we're really focusing on in this particular video. But mental health diagnosis is a very specific list of symptoms, and the individual has to have so many of those symptoms, and perhaps there might be one particular symptom they have to have and then so many of the others in order for the diagnosis to be made. Psychological interpretation is simply using what we have learned through psychological research and interpreted behavior based on what we know from research. So let's start with personality disorders, because it is character or personality, and those terms can be interchangeable. Many mental health professionals like myself, and if you did not know, in addition to the PhD in criminal justice, I also hold a master's degree in counseling, licenses to practice mental health counseling in West Virginia, and marriage and family therapy in Ohio. And then I'm also a clinically certified sex offender treatment specialist. I'm a clinical fellow of the American Association for Marriage and Family Therapy, and I'm also a clinical member of the Association for the Treatment and Prevention of Sexual Abuse. Okay, so clinicians like myself, we prefer the term characterological disorders rather than personality disorders, but the most popular way of saying it is personality disorders, so that's where we're going to stick. All right, so criteria for all personality disorders: an enduring pattern of inner experience and behavior that deviates markedly from the expectations of the individual's culture. This pattern is manifested in two or more of the following areas. Cognition, that's the way that the person perceives and interprets themselves, other people, and events. Affectivity, this is the range, intensity, lability, meaning the up and downness. Is it stable or is it not stable? And appropriateness of their emotional responses. Their interpersonal functioning, that is their relationships, and their impulse control. Now, hopefully, by the time you're taking this class, you've already had the criminology class. So you know that one of the theories of crime is self-control theory, where self-control itself, by itself, was the only variable that was found to be related to committing crime. The only problem is lack of self-control does not necessarily always lead to committing crime. In other words, there are just as many non-criminals with lack of self-control as there are criminals. Therefore, that particular variable is not really helpful in determining and distinguishing between who is and who is not a criminal. It's not helpful in discriminating between someone who might commit a crime versus someone who might not commit a crime. Okay. And then the enduring pattern is inflexible and pervasive across a broad range of personal and social situations. It's not just one place. It's got to be an enduring pattern. It has to be inflexible, and it has to be pervasive across a broad range of situations. Okay. The enduring pattern leads to clinically significant distress or impairment in social, occupational, or other important areas of functioning. So it might screw up relationships. It might lead to loss of jobs, things like that. The pattern is stable and of long duration, and its onset can be traced back to at least to adolescence or early adulthood. Now, onset, that doesn't mean full-blown, but you can start seeing at least some traits. The enduring pattern is not better explained as a manifestation or consequence of another mental disorder, and it cannot be attributable to physiological effects of substances or another medical condition, such as head trauma, okay? All right, so let's talk about the cluster A personalities in the diagnostic manual, and these are called the psychotic personalities. So paranoid personality disorder is a pattern of distrust and suspiciousness such that others' motives are interpreted as malevolent. Okay, so these folks may not appear psychotic to you necessarily, but they're highly suspicious. They always question the motives of other people. Okay, what is this person doing? Okay, schizoid personality disorder. This is a pattern of detachment from social relationships and a restricted range of emotional expression. There are probably a lot more people with schizoid personality disorder out there than we might think. In fact, some people might be misdiagnosed as being on the autism spectrum that really have schizoid personality disorder. And, especially if they're on the milder end of the autism spectrum. But these individuals don't really form close relationships. They detach themselves, and they don't really express emotion. So imagine some of the serial killers we know about, okay? All right, schizotypal personality disorder. This is a pattern of acute discomfort in close relationships, cognitive or perceptual distortions, and eccentricities of behavior. So that pattern of acute discomfort in close relationships, that can be similar to the schizoid personality disorder. But we also have to add, you know, this cognitive or perceptual distortions, meaning they might have hallucinations, true psychotic symptoms, and they might be very eccentric in their behavior based on what is the cultural norm. Okay, so let's move to cluster B. These are the selfish and dramatic personalities. So the first one is antisocial personality disorder. Now, before we move on, I want to point out that there are two numbers that you see with each of these disorders so far. The one that you see here that is not in parentheses, 301.7, that is the number, the code number for antisocial personality disorder in the Diagnostic and Statistical Manual of Mental Disorders. We are currently in the 5th text revision edition of that manual. The number in parentheses, F60.2, is the World Health Organization's International Classification of Diseases code number. Now, the International Classification of Diseases in the 10th edition has a much broader range of categories for this particular disorder. It's my understanding that the 11th edition that I have not yet seen is simply going to mirror the DSM. I hope not, but that's what I'm being told. But antisocial personality disorder, this is a pattern of disregard for and violation of the rights of others. People with antisocial personality disorder, they only think of themselves and what they can get out of something. They don't care to use other people. It doesn't bother them at all. All right, borderline personality disorder, a pattern of instability in interpersonal relationships, self-image, and affect, and marked impulsivity. That should say affect, not affects. That affect means emotion, but affect is the facial expression of the emotion. It also can include the body language that goes along with the physical expression of the emotion. But borderline personality disorder, these are the individuals that have this dynamic of I hate you, don't leave me. So one minute you are the wonderful knight in shining armor, and then the next minute you are the worst piece of crap in the cesspool. And there's very little in between. But you can see how someone who might seem calm and just really loving, and they have borderline personality disorder, and they literally go from 0 to 300 miles per hour in a split second, in how this person might end up committing murders. Okay? Think about a serial killer who picks up prostitutes, maybe not intending to kill them, but something happens in the interaction that enacts the borderline personality disorder impulsivity, and they end up killing them. Okay? That can be something that relates. All right, histrionic personality disorder. This is a pattern of excessive emotionality and attention seeking. These folks love drama. They want their life to be drama. Now, if you ask them, they'll say they're so upset that their life has been full of drama, but they want their life to be full of drama. They turn everything into a drama. Okay, you try to disagree with them or correct them or give them a better way of doing something, and they go off on you all over about how horrible, why are you putting me down so much? I'm not that stupid. And, you know, none of us are, but when we're wrong, but we all still can be wrong. All right. And then there's the narcissistic personality disorder, pattern of grandiosity and need for admiration and lack of empathy. Now, antisocials, and there are some folks that have antisocial personality disorder with narcissistic tendencies, but someone who is purely antisocial without any narcissistic tendencies, they could care less whether you like them. If they're trying to get you to like them, it's just temporarily so that they can manipulate you and use you. They can care less whether you actually do really like them. But the narcissist needs to be admired. Megalomaniacs are narcissistic. Hitler was a narcissist. He needed people to worship him. Cult leaders are narcissists with antisocial tendencies. They need their followers because they need to be worshiped, but they could care less about their followers and whether their followers are in any pain or not. They lack any empathy, okay, just like antisocial. All righty, so let's go to the cluster C, the anxious personality disorders. So there's the avoidant personality disorder, pattern of social inhibition feelings of inadequacy, and hypersensitivity to negative evaluation. Now, this might overlap a little bit with histrionic, but a person can become histrionic, overly dramatic, with the histrionic personality disorder. Avoidant personality disorder, if you correct them, they won't say anything. They don't go histrionic or dramatic, but they hate themselves because, oh, how stupid I am that I couldn't figure that out. Okay, now, if you are a student with avoidant personality disorder, then any correction that a professor makes might end up, giving you these really bad feelings of inadequacy when professors are supposed to correct you so you can get better at something. Okay, the difference between someone with avoidant personality and someone without it isn't that they're wrong sometimes, isn't that they don't need to be corrected, it's that when they are corrected, how they respond. All right, dependent personality disorder, a pattern of submissive and clinging behavior related to an excessive need to be taken care of. I got to have somebody to take care of me. I got to have somebody to take care of me. But what's interesting is there are a lot of individuals with dependent personality disorder that also hate that disorder, and they kind of rebel against it. And so they're so afraid of losing the person that is taking care of them that they never disagree with them. They always go along and let that person take care of them, that they might go out and become a serial killer where they can be the one in control. I'm just throwing out some ideas as we go along. And then there's obsessive compulsive personality disorder. This is a pattern of preoccupation with orderliness, perfectionism, and control. Now, let's separate this from obsessive compulsive disorder. Obsessive compulsive disorder without the word personality in it. A person obsesses about something. So and that obsession is an anxiety. That's obsessiveness is anxiety. So they obsess about something. So a person might obsess about their house burning down, but they compulsively turn the doorknob 3 times before they open it because they believe that will prevent the house from burning down. So that compulsion calms the anxiety of the obsession. Or I'm afraid that the walls are going to fall in on me, cave in on me. But if I count all the bricks in the wall, then that will calm my obsession about the wall falling in on me. Okay, that's obsessive compulsive disorder. There's an anxiety, something that I obsess about, something specific that I obsess about, and I engage in this compulsive behavior to calm the obsession. One last example of that, germs. I'm afraid that I'm going to get germs, so I'm constantly washing my hands. And for a brief moment after washing my hands, I'm not anxious about the germs. But then, see, with obsessiveness means that it continues. So I continue to obsess about it. Then I got to wash again to calm the obsession. Then I got to wash again, and then I got to wash again. So obsessive compulsive personality disorder is where I want the world to be perfect. The world needs to be the way I want it to be. Okay. So the cans in my cupboard have to all be organized and facing the same way. My personal space has to be perfectly organized with nothing out of order. So that's more the obsessive compulsive personality disorder. So there's OCD and OCPD. All righty, so those are the personality disorders. So let's talk a little bit about the psychotic disorders. Now, key features of psychotic disorders. Now, remember, there are some psychotic personality disorders. They've got the enduring pattern, that kind of thing, but it's more of a personality issue. So delusions. Now, delusions are fixed beliefs that are not amenable to change in light of conflicting evidence. For instance, I had a counselor friend who, in the span of 2 months, had his fiance in the engagement and breakup with him, had his sister murdered, and both parents died. And now, without all of those particular triggers, he may never have developed a psychotic disorder, but he did develop a psychotic disorder. Now, he was a therapist, and when he started having some mild symptoms, the delusion was the first one. Now, this all happened when Bill Clinton was president, and he was working for the federal government. He was working for the Veterans Administration, and he started to believe that Bill Clinton himself knew who he was and was targeting him to fire him from the VA hospital. Okay. Bill Clinton had no idea who he was. Okay, President Clinton didn't know who he was. Okay. So that was a delusion. And I knew the folks that were in the administration at the hospital where he worked, and they were concerned about him. They really cared about him. Nobody was targeting him, but he began to become delusional that people are targeting him. Hallucinations. So these are perception-like experiences that occur without external stimuli or stimulus. Stimulus being one, stimuli being two or more. So this may occur in a sensory modality, but auditory are the most common, with visual being the second most common, followed by touch, smell, then taste. So think of the five senses. So it can occur in any sensory modality, any of the five senses, but auditory or sound hallucinations are the most common. Hearing things. They might hear, "Kill yourself, you're worthless." And it can be very scary just the way the voices sound. So visual are the second most, so seeing things that aren't there. Touch would be the third. Smell, then taste. Yes, there are some folks that hallucinate smells and some that hallucinate taste. Disorganized thinking or speech, such as loosening of associations, tangentiality, or word salad. Now, word salad is just throwing a bunch of words out that doesn't mean anything. Loosening of associations is associating two or more things together that have absolutely no association. Tangentiality means they just keep talking. They keep talking about subject after subject, and they keep talking, and they don't get off of it. Okay, grossly disorganized or abnormal motor behavior, including catatonia. Catatonia, or a catatonic state, is the person is definitely not in a coma, but it's like they're sitting there like a vegetable. So they're also what we call negative symptoms. Now, this is diminished emotional expression. So it's like, the old phrase, the lights are on, but nobody's home. So it's like the person, and this is especially true of catatonia, it's like there is no emotional expression. It's not blunted, it's just not there. Avolition means that they really don't get up and do much. Alogia means they don't talk much. And hedonia means that they don't find pleasure in things. And asociality means they just don't socialize. All righty. Now, it is important to note that all of these symptoms may be explained by substance use or medical issues. In other words, they're not, if it's caused by a medical issue or by substance use, then once the medical issue or the substance use are resolved, then those symptoms will likely be resolved. Now, this fact limits the utility of these diagnoses in the behavioral analysis of crime scenes. So all of these diagnoses, all of them, every last one of them. So remember the fundamental attribution error that we were talking about earlier. Remember it, because the person might be under the influence of substances, or they might have a medical issue. All righty, so I just want to make a brief statement about the bipolar and related disorders. Bipolar disorder is not mood swings, all right? If you have mood swings, that doesn't mean you have bipolar disorder. Bipolar disorder is going back and forth between manic episodes and depressed episodes. There are some folks with bipolar disorder that they have pretty significant manic episodes, but their depressed episodes are very mild. They may not even recognize they're depressed. Okay, but just having mood swings does not make bipolar disorder. Everybody has mood swings because everybody experiences a whole range of moods. We call that a full range of emotion. When a mental health therapist writes full range of emotion in a record, they're saying this person does not have that mental symptom. They're saying this is normal, this is good. Okay, so having emotions, different emotions, is a normal thing. Everybody gets mad sometimes. Everybody gets scared sometimes. Everybody gets sad sometimes. That's normal. That's the full range of emotion. That is not bipolar disorder. Most of us might experience those, all of them, every day, depending on what's happening in the moment, because our emotions tend to be based on what we're facing in the moment. They tend to be very contextual. They are a state in the moment, not a trait. Now, some people do have trait emotions. Some people are just angry people. That's anger as a trait. But all human beings have anger as a state at times. Okay, so bipolar disorder is the alternation between a manic episode and a depressed episode. That's all it is. So there is bipolar 1, which is full-blown bipolar disorder. There's bipolar 2, which is less severe. But usually when someone is in a manic episode, they're out of control of themselves, and they're more likely to be a victim rather than a perpetrator. But it's important that you understand that, so that if someone tries to tell you they probably have bipolar disorder, well, maybe not. Okay. All righty. So that is the end, and I'm going to stop the screen share and get back to the to where you can just see me. Okay. Now I know this has been a little bit of a longer video, but it was very important that you hear this stuff. All right. So we will see you next video.